Great. Welcome, everybody. Thank you for joining us. Sweet. Great. So I'm Mary Mulcair. I'm one of the attending physicians at Weill Cornell Medicine in New York City, and also a geriatric emergency medicine physician, as well as a physician that does telemedicine. And I'm here with you today to moderate a panel, and we're going to be discussing telemedicine for older adults. Is it viable? Show me. So with the growing number of older adults, the need for expanded resources and new creative ways of supporting this population is in demand. Telemedicine and virtual healthcare have moved from a low volume niche service to an important component of mainstream medical care. We're here today to demonstrate why these two statements are not independent, but rather when combined have the potential for a significant impact on the care of older adults. So while the groundwork for this was already in place, give or take 14 months ago at this point, courtesy of COVID, we've seen a rapid implementation of pilot processes supporting our supposition. We acknowledge that perceptions do exist, right? People think that older adults can't manage technology. Older adults want to see their doctor in person, not over a monitor. Providers can't effectively communicate with older adults, and providers cannot conduct an adequate physical exam over video. But we ask you, have you tried, right? Those of us that have been doing this for a long time disagree with these sentiments. And the literature is actually catching up with us as well. So to address this topic today, with the goal of demonstrating the breadth of options and effects that telemedicine can have on our older adult population, we bring you this panel. Our panelists are going to discuss everything from urgent care done virtually, virtual urgent care, community teleparamedicine, home-based care of at-risk subpopulations, telemedicine as it allows continuity of care within a system and for specific populations, and also using telemedicine in skilled nursing facilities or assisted living facilities, and also ameliorating the potential for transitions of care. So without further ado, each of our panelists will present their sections. If you have any questions, please feel free to put them in the chat as we go along. We'll be holding all questions till the end, at which point I will provide them to the different panelists at which they are directed. So without further ado, our first panelist is Dr. Michael Stern. And Dr. Stern is the Chief of Geriatric Emergency Medicine and the Director of the Geriatric Emergency Medicine Fellowship at Weill Cornell Medicine. And he is here to discuss practitioner-assisted virtual visits. So Michael, thank you.
Thank you very much, Mary. I just want to let you know I have nothing to disclose except for the fact that I'm happy to be here. Next. So the real question here is, where do older patients fit in? The reality is there's a broad spectrum of utility for telemedicine and caring for older patients, and successful implementation of various programs exists. Across NYP, we have a lot of telemedicine services. I'm going to be talking about only two, the ED Express Care and Community Tele-Paramedicine, or CTP. Next. So we've been at this for a little while, Express Care for about 5 years, and then the full implementation of CTP since mid-2019. Next. So ED Express Care. So this was the initial controlled rollout of telemedicine as part of the lower acuity urgent care fast track area in our hospital's ED. We offered it to all patients, all adult patients rather. But I must admit that despite our robust geriatric EM program at our hospital, we suffered from a little bit of ageism in the form of doubt, wondering how the older population was going to adopt telemedicine in terms of technology, some of the things that Mary brought up. Next. So this is how it works. A patient arrives, they get triaged ESI level 4 to 5. They have an in-person medical screening evaluation by an APP. They're offered the private express care visit track. About 5% say no, and so they go via the normal fast track way of caring. But if they say yes, they're brought into a specific room. Whatever needs to take place for their visit, i.e. X-ray, pain medicines, ACE-RAP, is done, and then they're directly discharged by the express care physician over the telemedicine monitor. Next. So between July of 2016 and December 2020, we saw 15% of our express care patients as those older than 65. And this matches about the percentage normally for the low acuity area. Obviously, our higher acuity area, much higher percentage of older patients. And we actually at RAD are about 10% above the national average. The length of stay for express care patients, 41 minutes, which was even a little shorter than the younger adult patients we saw via express care, and significantly less than the 2.1 hours, which was the length of stay for the normal fast track method of seeing patients. Next. The repeat ED visits unplanned within 72 hours was the same for older versus younger adult patients seen through express care, 1%. And this was a little bit lower than the traditional fast track of 3%. As well, those that required inpatient admission, extremely low, 0.1%. And this was the same across both age groups. There was equivalent very high patient satisfaction scores. And we even did a sensitivity analysis with an age threshold of 75, and that did not change the primary results. So these findings seem to support that there are groups of older patients for whom ED telemedicine can provide safe and effective care with low bounce back rates and a high degree of patient satisfaction. And it perhaps speaks to actually an intuitive understanding by older patients of the paradoxical virtue and power of technology in the form of a virtual encounter. And namely, that's the essence, that the connection between patient and provider, and being able to tell your story about what ails you and having someone across the monitor listen carefully and observe carefully is really what it's all about, and then the care can be delivered properly. Next. So now we're going to switch gears to CTP. Next. So this is a very different type of model of physician-assisted virtual care. This is an innovative model of population health delivery for high-risk patients, combining home visits by specially trained community paramedics, supervised in real time by emergency physicians via telemedicine. Next. How does it work? You identify populations at risk. We started off with heart failure and COPD patients, often right after an inpatient stay, sometimes in the ICU. And then our very experienced RN coordinators set up the visit. Then step 3, the evaluation takes place in the home at a designated time by the paramedics and the EDMD via telemedicine. And then they're treated in their home in various fashions. Occasionally, they need to be transported to the ED. And in the future, we may actually be able to transport them directly to an alternate site, like, for instance, dialysis. Next. So these are the operational metrics. We saw all adult patients, but the mean was 71 years old, skewed a little female, a little bit non-white. And within a study period, 127 CT patients were seen, averaging 6 visits per patient. Next. This is the work time analysis. Effectively, 2 medics working 10 hours a day see approximately 5 patients a day. And usually they perform tasks in parallel. One, for instance, does the exhaustive medication reconciliation, while another one obtains ECGs, wraps legs, gives medicines as needed. The average time is 105 minutes, so it's somewhat labor intensive, and that's the breakdown. Next. Here's a quick case study. 81, complicated history, bad heart failure patient due to amyloid. Prior to CTP or healthcare utilization in the last 2 years, 8 ED visits, 4 admissions. Since joining CTP in August of 19, 2 ED visits with discharges both, and then 1 direct admission from her home after a CTP visit for a heart failure exacerbation that was not deemed safe to care for by the medics and the doctor via CTP. Next. What are the goals? Improve access and quality of care, reduce 30-day readmissions rather, improve understanding of meds, diet, and follow-up appointments, improve med adherence, which is a big thing, avoid unnecessary ED visits, avoid unnecessary admissions, and actually reduce the inpatient length of stay by offering this immediate follow-up in the home, that sort of concentrated care by this program. Next. So interventions within the last 90 days, 29% of visits had them. 22% had medications prescribed, sometimes IV via PIC. 25% had medication discrepancies that were identified, and that obviously is a huge setup for a disaster. So that was an important metric. A quarter of them had care coordination issues identified and addressed, and a little over a quarter had consults made real time during the visit via secure chat or by a phone conversation with either their PCP, their heart failure cardiologist, their critical care pulmonary doc, or some other subspecialist. Next. So patient satisfaction surveys, the patients love them, particularly the older patients. They really felt secure having the medics come, having the physician talk to them over the monitor, feeling that they could stay at home longer than they otherwise might. So it was very successful from their standpoint. Next. And here's some relative rate reductions of outcome per 30 days while in CTP, a 40% reduction in ED visits, a 13% reduction in admissions, and a 25% 30-day readmission reduction. Next. So for NYP, CTP is both expanding and integrating. We're now seeing not only heart failure and COPD, but end-stage renal dialysis patients and complicated diabetic and hypertensive patients, and incorporating a whole bunch of different platforms using telemedicine with the CTP group. Next. Thank you very much. I hope you have some questions at the end. I appreciate it.
Great. Thank you very much, Michael. And you actually have several questions in the chat if you want to take a look as Erica launches into her part two.
Terrific. Thank you.
Thanks. So next we have Dr. Erica Olson, who's joining us. So she is the Director of Virtual Health Services at Columbia University Medical Center of New York Presbyterian. And she's also the chair of the SAEM Telehealth Interest Group. And so she's going to be discussing the direct to consumer model of telemedicine delivery, which is one that's more familiar to all of us in general. So Erica.
Thank you. Yes, I'm going to talk about a patient care model that we refer to as virtual urgent care at NYP Columbia Cornell. So just so we're all on the same page, I thought I would briefly describe it here. It's generally referred to as a direct to consumer model, if you've heard that term used before, whereby the patient or the consumer directly accesses a board certified emergency medicine physician in our case. And they do so by their, you could do next slide, excuse me. They do so by their smartphone, tablet, or their computer. They don't need to have any prior relationship with the provider or the institution in order to participate in this, but they must create an account if they don't have one already. Many patients find us by doing an online search for virtual services. If they happen to choose our service, the process of creating an account is self-directed with identity verification built into the process. And what that really looks like to the patient is they have to answer a series of questions similar to those in a credit check, like which of the following was the model of your first car, where have you lived before, things like that. And after a process that takes about 10 minutes, the account gets created. If they do have difficulty with that step, there's a phone number for assistance posted. Once it's created, they can choose their provider and their appointment time. The appointments are currently booked in 15-minute slots, but this is customizable and might be a consideration for this population if we might think we might need more time. The provider is then alerted that the patient's ready, and so they can start the visit. And we do accept insurance payment, but there is a self-pay option as well for our particular model. Any prescriptions get sent electronically to the patient's pharmacy, and if the patient requires any lab studies or imaging studies, then they get sent to the respective locations with location-specific instructions provided to the patient. Two last mentionables I'll just make. The current legislature requires that the telehealth provider be licensed in the state where the patient is physically located at the time of the visit. The patient gets asked this question when they make the appointment, and then our providers verbally ask again just to be sure. And this, of course, may all change as telehealth regulation evolves. The second point I just want to make is that the visit must be created within the patient's account, not a family member. And it's not uncommon for us to have a patient call in and then say that they're in fact calling for their mother. When this happens, we have to kindly ask them to end the visit and reestablish the connection with the correct patient's chart. So hopefully that just paints a picture of what an older adult patient needs to do in order to connect with us. Next slide, please. As we all know, the 2020 pandemic brought with it a very strong stay-at-home message. And there was a great deal of fear and anxiety around physically going into the emergency department to seek medical attention. Everyone was afraid they would contract COVID or be admitted to the hospital and unable to have their loved ones visit, and then the ultimate fear of dying alone. So New York, where, I'm working from New York. And so in the spring of 2020, just to kind of set the stage for this study, it was the epicenter of the pandemic at that time. Geriatric patients were at especially high risk. By June 2020, the cumulative death rate by age in New York City was about 1,500 and 100,000 for age 75 and above, while it was only 187 per 100,000 for ages 45 to 64. So we started to notice what we thought was an uptick in the usage of virtual urgent care by the older adult population. And we knew that we wanted to look at this more closely once everything had calmed down. Next slide, please. So several colleagues got together to evaluate the use of virtual urgent care and provide a descriptive analysis of what happened during this peak. So this is a retrospective chart review by 6 of my colleagues, all emergency medicine physicians. We looked at patients who were 65 years and older who were seen through this model during the surge. And for comparison, for volume, we looked at the previous year during a similar time frame during what was an ordinary flu season. We looked at an array of characteristics to assess their utilization and to identify areas for further investigation and interventions that we might make to improve their access to care. Next slide, please. This is being presented as an abstract here at SAEM as well by Dr. Ellen Sano. But essentially, we saw an exponential increase in utilization during the pandemic as compared to the previous year timeframe. Next slide, please. 140 charts were reviewed. The mean age was 73. There was a female majority, mainly English speaking, with a predominance of the visits concerning COVID. The majority of the patients in our data set did not use assistance for the platform, although it was close to 50-50. But of those who did use assistance, patients over age 75 were more likely to use family to assist than those under 75, which is an important point. 92% of the patients had not used telemedicine previously in the prior 3 months, just to use that as a measure of were they experienced at this. And 22% of the encounters needed an emergent ED referral to get further evaluated. Of that 22%, the median age for those who were referred emergently, they were older. They were 78 versus the people who were told to have more routine follow-up care were 70 average. So next slide, please. So where do we go with this information? Foremost, because the emergency just kind of came upon us, we didn't have the opportunity to define measures that we would have loved to obtain, including some more details on the patient experience. It would have been nice to just ask them, how did it go? Was this difficult? Is this your third attempt to get on? We also were lacking platform information. So we would have benefited from seeing, how many dropped calls and how many attempts and how many times a patient canceled a visit. I think that would have helped us a lot as well. And so having more data on the provider experience, the medical outcomes of all of these patients, all of this would help us to develop interventions to improve access for these older adults. What I can say for sure is that caregivers can play a pivotal role in assisting this population with access and more attention to informing the caregivers on issues around telehealth usage will likely benefit this patient population. In addition, we'd like to see embedded captioning for patients who are hard of hearing as well. So hopefully that was some good information for us to build upon. Thank you.
Thank you. Thank you very much, Erica. And next, we're going to have Dr. Janine Smith, who is representing the San Francisco VA healthcare system and their director of telemedicine. And she's going to be presenting on a pilot telemedicine program that was created for this special population in need, being those in the VA system, and showing the impact on older adult veterans. Thank you. Go ahead, Dr. Smith.
Thanks for having me and giving me this opportunity. This program started in the San Francisco VA ED prior to the pandemic, so June of 2019, at the time that the Mission Act was initiated. It was an attempt to offer our patients a virtual option to stay in the integrated network rather than using the community options that they had been given. So we started as just 3 people during the day in the ED. We were taking calls referred to us from the call center. The RNs there would do their triage algorithm, arrive at an ED disposition. And if the patient consented and the RN felt it was appropriate, it was completely up to them to refer to us, and we would see the patient. So that went on, that was the pilot. That went on for about 6 months. And then when COVID arrived, those same RNs take the calls from the rest of the network in the after hours, the when hours, the weekend, holiday, evening, night. And so the San Francisco call center was getting all the calls from all of Nevada, all of Northern California, and all of the Pacific Islands. And they noted, and the patients complained, that they didn't want to go to the emergency department, especially for non-emergent things. Even for emergent things, they didn't want to go because of fears of COVID. And so to protect the patients and staff, we expanded very rapidly. We scaled up to cover the network. So next slide, Mary, thanks. I just would draw attention to the age range. This is a typical age range of calls that the call center receives. Our initial 6-month data at the time that I think I put this first together was that we had 42% of the veterans that we were serving with our virtual urgent care were over the age of 70. And that, I was wondering, I looked back at this yesterday just in preparation for this call to see if that number had dropped off now that some people have vaccines and face-to-face options are becoming more available and more acceptable. And actually our percentage is 44% are over the age of 70. So we are seeing a lot of patients virtually, and almost all of them would have otherwise been referred to the emergency department by our nurse triage system. So, and then I'll talk more about the modality on the next slide. You can go ahead next, Manny. So this is this is currently a manuscript, but these are some results from the first 6 months. We are only looking at the when hours for this purposes rather than the daytime in San Francisco, because we didn't expand to the daytime in the other facilities in the network until December. So this is the first 6 months. Our nurse triage protocol is fairly conservative in the VA, but it universally arrives at a ED disposition in approximately 30% of all symptom calls. Then another 30% arrive at a triage to the clinic. But those go along with the clinic dispositions. The nurses also arrive with their protocol at a time interval. So a patient who were to call the call center on a Friday at 4 o'clock and be given an interval of 2 to 8 hours, even if it's in clinic, that patient gets upgraded to the emergency department. So you can see how this ends up with a lot of patients being referred to the emergency department. All of those patients who would have been referred to the emergency department for by nurse triage were eligible to be referred to tele-urgent care, virtual urgent care. Only a third were, and the reasons are multifactorial, but it's actually not that they were sicker. That is another analysis for another presentation, but it was primarily when the nurses were too busy. It took time for them to refer to us because we had a process. And those patients would just be referred to the emergency department. The ones we did see, we saw 25% on video and 62% we had a visit by phone, and the remainder was a consultation just with the RN. As you can see in the bottom row, we referred the patients that we saw on video only 14% of the time to an emergency department. And these were patients who all would have gone or been referred. We don't know if they would have gone. We don't have that study, but they would have been referred to the emergency department. And then of the patients we saw on telephone, 20% were referred to the emergency department. Our failure rate is what I would call the last row. Those patients who went to an emergency department within 72 hours who we did not refer. So if we thought we took care of the problem. And that was actually equivalent between a phone visit and a video visit. Next slide, Mary, thank you. These are just some more characteristics on age and other factors. The average age for a phone assessment was a little older, 65, with 59 being the average age for video assessment. And also what we saw the patients for varied slightly. We were much more likely to see people on video with musculoskeletal and skin complaints than other system complaints. Whereas with telephone, it was a little bit more evenly distributed. We saw respiratory complaints at pretty much equivalent between the two. Go ahead and go to the next slide, and I'll just wrap up with some take-home points and observations. Since I do this work, I would say that it's very common for the older patients to initially prefer a phone, but when presented with the advantages to video, when there are some, they will try it. It's just there's a little bit of resistance at first, but we convert a lot of people to video that start with phone. Some have smart devices, but will not claim to be video capable when asked by the nurse triage. And the other group is that when they're highly motivated, when they're sick, they're more likely to get help from family members and caregivers and friends. Older veterans also often have peripheral devices reporting biometric data at home, which is super helpful. In the beginning of the pandemic, there was a run on thermometers and pulse oximeters, as probably most of you experienced. But later, those things came back. And of course, the people who had COVID, we saw many of those and followed them at home, especially the more concerned ones who were monitoring their pulse ox every 5 minutes, you know. So we did utilize and do utilize those devices quite frequently. We do think this is benefiting veterans. The satisfaction among everyone has been really high, and that we think we can probably avoid at least 50% of ED referrals, at least in the VA. So that is where I would wrap it up. Thank you.
Great. Thank you so much, Janine. You also likewise have some questions in the chat, which you can feel free to address as we go along. So thank you. Next, we're going to have Dr. Kevin Bice, who's joining us from UNC, where he is the Vice Chair of Academic Affairs, as well as the Co-Director of the Division of Geriatric Emergency Medicine. And he's going to be describing the implementation of telemedicine in evaluation for older adults at skilled nursing facilities and assisted living facilities, and as a way of delivering care to those who need higher levels of care and potentially ameliorating those transitions of care. So Dr. Bice.
Awesome. Thank you so much, Dr. Mulcair. And thank you for organizing all of this as well. I don't know if we've given you enough credit for herding the cats and getting them across the finish line. So thank you so much for doing that. I'm going to be brief. You know, I've had the privilege over the last few years of working with a couple different enterprises that have really worked on delivering using telehealth to treat in place in skilled nursing facilities and sometimes long-term care facilities, as opposed to transferring to the emergency department. Next slide. By way of disclosure, I currently advise one of those companies called Third Eye Health, and some of the information I'm sharing comes from that, but not going to talk about Third Eye. But I do serve as an advisor for that. Next slide. You know, it's not rocket science, and we're all saying the same thing, but particularly for vulnerable patient populations, whenever possible, move the information, not the people. If COVID has taught us nothing else, the construct of bringing all the people with contagious illness to one place and having them hang out together is not a long-term winning strategy. And so much of what we are doing is can absolutely be conveyed by sharing information and not moving the people to the information, but rather the information to the people. Next slide. So before COVID, right, skilled nursing ED transfers before COVID, there's about 14 million SNF to ED transfers per year. And thanks to Dr. Kennedy's on this line and the other folks who put together a paper on some of this information. Coming from disparate sources, depending on how you calculate it, but at least 23% of those transfers are avoidable. That's using a rubric where you look at it in our current way of doing business. And if we're creative, many more than 23% are avoidable. And of the resulting hospitalizations, many of those are avoidable as well. The majority of those based on a MedPAC group that came out, Medicare Payment Advisory Commission. Again, different methodology by different studies, but I think our experience would echo the sentiment that oftentimes once you get on the conveyor belt of a skilled nursing facility patient arriving in the emergency department, it's hard to turn that around. And admission may be the potentially avoidable, but almost inevitable result of that transfer. All of us are aware of the problems that come from medically unhelpful admissions, and the cost is at least $10,000. That comes from health affairs data from 11 years ago. Some of the data I've looked at recently would suggest $17,000 or $18,000. But the important point of the cost here is that if we're creative about how we help treat people where they're living, and in this case, skilled nursing facilities, then we have plenty of margin to work with to offset some of those costs if we're able to connect those dots. Whether you're using 10,000, 17,000, 20,000, it almost doesn't matter. We're not getting a good bang for our buck today. Next slide. COVID, obviously, it's already been said, made it all worse. What a terrifying year to be older in our country. What a doubly terrifying year to be living in a long-term care facility or have to end up in a skilled nursing facility. And an equally terrifying time to end up in the emergency department, right? I mean, so we all know this. We don't need to go into the details here. I would just put my usual shout out here for the fact that caregivers, several of us on this line have worked on this, caregivers are not visitors. And so, letting caregivers in when possible is really critical for well-being. So next slide. So how can you do it differently? And we're really looking at, in this case, it was two different patient populations, two different sort of entrepreneurial starts on this. The one on the left has been published. The one on the right is some more recent experience, not yet published. But the one on the left is and Dr. Kennedy just put in the blog on caregivers not being visitors. I just can't get over how important I think that is. And Dr. Kennedy's worked on a lot of those issues. But the one on the left really pointing out is a paper that came out in 2020, looking at 6 urban skilled nursing facilities, 2,300 intervention patients. And basically, there was a control group that didn't have access to telehealth. So here's a group that has access to telehealth. And that model involved an EMT at bedside, telehealth with emergency department physicians, and able to provide medications and assistance right at the bedside. And then the other one did not have access to that. And then on the right is a similar model, except without an EMT at the bedside, but using virtual care for 50,000 encounters in 2020. And both of the results, why don't we go to the next slide, are actually highly similar. And this is the published data from the 2017 study, but it takes a second to wrap your mind around it. So I'm going to point out what's happening here. So in all conditions, of the telehealth available group, 27% of those patients had care escalation, meaning they got sent to the emergency department. 71% of the patients that did not have telehealth available got sent to the emergency department. Not shockingly, that was statistically significant, 23 or 27 versus 71%. If you look down at some pretty critical illnesses there, congestive heart failure, COPD, complications of diabetes, it really, there's some pretty striking differences in how often patients went to the emergency department if they didn't have access to telehealth than if they did. And anecdotally, I know this is academic emergency medicine. Whoops, I'm on my time. But anecdotally, I'll share as someone who's provided care this way, it is remarkable the kinds of interventions you can do. I've gone so far as to use CPAP machines in nursing homes and nitroglycerin underneath the tongue and turned around flash pulmonary edema in patients, in part because I think we're able to do it so quickly. We're able to get to the bedside so quickly the condition hasn't evolved as much. So anyways, I that's not data that I'm sharing right now, but I've had several years of experience working in some of these forums, and you're able to do some pretty remarkable work if you can get to the patient a little bit sooner. And so this data it resonates with my experience for whatever that's worth. Next slide. So obvious considerations. I think these are important though, as you think about these models and your own experience. There is a push towards using less experienced clinicians in a lot of work. Telehealth requires very experienced clinicians for complicated patients, right? You've really got to be able to not just follow your traditional algorithm, but think a little differently about how you usually treat conditions and get creative. And in order to be safely creative, you should have some experience. That person on the other line should have some experience. Reevaluation is critical. You don't have a CAT scan at the nursing home. So abdominal pain is frequently treated through frequent reevaluation, as opposed to the same person you might put into a CAT scan at your emergency department. Skilled nursing facilities are optimal for this kind of setting because you can train the people that work there to be your presenter. And I will say my own opinion is that it's really has a lot to do with seeing the patients. Because I do some of this work, I'm approached all the time by the people that have the latest gizmo of like the fanciest stethoscope or the thing that lets you look into their ear. I really, for the most part, want to see the patients have accurate vital signs and the ability to monitor them over time. That's my personal approach. Next. So, I think it just needs to keep happening. I think it makes sense. And we also need to get more creative about how we can treat acutely ill patients at home. I think that's it. Sorry for going over.
That's okay. Thank you very much. Love hearing from you always. So thank you. And finally, we're going to have Dr. Kennedy, who is the Division Chief for Geriatric Emergency Medicine at MGH. And she is going to be joining us to talk about another subpopulation that's very near and dear to many of our hearts, and caring for patients with dementia, and specifically how telemedicine can help them in the home environment. So with that, Maura.
Thank you very much. If you can go to the first slide, please. So as we all know, individuals are living longer lives, and this means that the number of persons living with dementia is increasing. And you can see in this graph that over the next 3 decades, the people in the United States living with dementia is going to more than double. Next slide. So we wanted to talk a little bit about some of the unique benefits of telemedicine for individuals with dementia. And right now this is theoretical. We don't have data on this, but as most of us have experienced, older individuals with dementia can get quite agitated. Common triggers for agitation in persons with dementia are change in routine, a new environment, and environmental noise. And if that sounds familiar, that's basically the emergency department. And a key strategy that caregivers use to minimize behavioral outbursts is maintaining a consistent routine. It's really critical. The ED disrupts that. Additionally, individuals with dementia are at increased risk for delirium, and common delirium triggers, change in environment, sleep disturbance, restraints, those also are very common in the emergency department. So given these factors, an ED visit seems a potentially very high risk to trigger agitation or delirium in someone with dementia. Next slide. And though we typically focus on the ED environment, for many caregivers, the process of actually getting to the ED is harrowing. One caregiver that I interviewed told me that her husband always had to be moving, otherwise he would get agitated. And she dreaded getting him into the enclosed space of her car. And then every time she had to stop in traffic or at a traffic light, and we live in Boston, so that's a lot, she was really worried that he would try and get out of the car. But even when they made it into the hospital, the ordeal wasn't over, as they were usually shuttled into a crowded waiting room and sitting there for hours before they got back to be seen by a clinician. So a trip to an emergency department may have an adverse impact on the well-being of a person with dementia, but also the caregiver. Next slide. So this has some results from a survey that was conducted of individuals going to a memory clinic in the VA. And they basically had an initial intake visit, and then the clinic offered patients and their families an option to follow up in person or via telemedicine, and then surveyed to find out why they chose that particular option. And for the people who chose the video option, the top two reasons that they chose that were concerns about travel, 24%, and importance of preserving a veteran's daily routine. That's 22%. So it really reinforces that idea that the ED can be extremely disruptive and that a telemedicine approach could be helpful in that regard. Next slide. So those are potential benefits for persons with dementia and their caregivers for telemedicine, but obviously there are going to be some unique communication considerations. Now, we know this, but it's really important to remember that memory and communication abilities vary tremendously by the stage of cognitive impairment, which you see on the left-hand slide. In mild cognitive impairment and early dementia, the patient may be able to answer some of your questions, particularly very direct, simple questions. But with more moderate and severe dementia, the ability of that person with dementia to provide history is going to become increasingly impaired. And by end-stage dementia, patients are typically nonverbal. So how you engage with the patient will depend on the stage of dementia, but also the complexity of the complaint. And obviously getting collateral information, like in the emergency department, from a caregiver is just utterly critical. The caregiver may also have some recommendations about how you should engage with the patient. One caregiver that I spoke with said that until his wife was in the end stage of her dementia, she would sit side by side with him for every medical appointment, and that was his preference for all appointments. But another caregiver that I spoke with told me that she actually preferred to be interviewed separately. Her husband would become very upset if people were talking about him or contradicting him. And I think all of us have had experiences where we've done a full HPI in a room with a patient, walked out of the room, the family member follows us, and then starts correcting the misinformation and providing additional history because they didn't want to do that in front of the patient. So if you're going to approach a telemedicine encounter with someone with dementia, you're going to have to consider how you're going to interview that caregiver and patient dyad. And at the bottom of this slide, you'll see some tips from the Gerontologic Society of America around communicating with individuals with dementia, some do's and do nots. And we just put the link to that in the chat. It's a great document. It's about older individuals, but has specific chapters on dementia. Next slide. So, so far I've been discussing mainly video-based telemedicine, but as the prior speakers have mentioned, there's just an extended spectrum of home-based care options to address acute medical complaints, like mobile integrated health with paramedics, which was already discussed, as well as hospital level care in the home. And so factors that might influence what level of care intensity is needed to evaluate a person with dementia with an acute medical condition are your dementia severity, the complaint complexity, or even specificity, obviously what matters to the patient, and then caregiver factors. Next slide. So if a person with dementia has a red eye, this could potentially be managed via telemedicine, regardless of dementia severity. Similarly, if they have foot pain, with the patient's help or with the family's help, you could be able to do a physical exam, including palpation, and use that to guide what diagnostic recommendations you have or treatment recommendations you have, aligning that, of course, with care preferences. But for patients with severe dementia and higher complexity of complaint or non-specific complaints, that's where an in-person evaluation may be critical. Next slide. So this is a real-world case from our mobile response program. We were asked to see an 86-year-old man with advanced dementia. He was nonverbal and he was bedbound. And the family called the PCP saying he seems to be wheezing and he's definitely lethargic. The PCP knew that given the severe dementia and this very nonspecific complaint, there's no way he would get enough information via phone or video to understand what was going on with this patient. So he did what was natural. He said, you need to take your father to the emergency department. But the family really preferred an in-home visit. And so he activated our program. Next slide. When EMS got there, he had normal vital signs, although based on yesterday's AGM talk, I should probably say his blood pressure was 120. He was somnolent, but arousable. He was pallid. And the aide who was at his bedside said he just passed a large dark stool. The emergency physician that was working with the paramedic ordered a point of care hemoglobin, which resulted at 6.1. This was an acute drop. And that really facilitated an early goal of care conversation with his family, discussion of what care preference would be. And the patient was enrolled that day in a home hospice program. And he died at home about a week later. Next slide. So as Dr. Bice just noted, there's active growth research and programs around telemedicine and mobile integrated health programs for individuals in assisted living and long-term care facilities. This is from a research study by Drs. Gillespie and Manish Shah, who looked at high-intensity telemedicine for patients with dementia in senior living communities. And they had a facilitator who would go into the patient's home to assist with the virtual visit. And in this pilot study, they demonstrated an overall decrease in ED visits and ED visits resulting in admission. So hopefully with the growth of telemedicine and mobile integrated health in the pandemic, we'll have more information about how optimally to interact with our patients with dementia via these platforms and the outcomes associated with it. So stay tuned. Thank you.
Great, thank you all very much. So I think we've hopefully made a clear case as to why older adults stand to benefit dramatically from a broader implementation of telemedicine across the board. And we as a group are here to help any of you who are trying to do that at your institution. Happy to field questions and happy to help you in the future if anything should come your way. The topics that we've covered today have included virtual urgent care virtually, CTP, continuity of care within systems, SNF care, transitions of care, home-based care for at-risk populations. And here's, again, list of the panelists with emails just for your own reference if you'd like to take it with you from today. I think with that, we have about 3 to 4 minutes. And with that, having watched the chat, thank you for your questions and thank you to the panelists for answering many of them along the way. I think there's one question early on, which is actually pertinent to several of our panelists. And I think Dr. Bice and Dr. Kennedy made a very strong argument for the involvement of caregivers and why that's so important. And one of the early questions was directed at Dr. Stern's talk, I think also applicable to Dr. Olson and Dr. Smith's talk, is have you seen a variation in outcomes when caregivers are present during these virtual urgent care visits? And so Dr. Stern, that was for you in terms of express care. I think Dr. Olson, you sort of specifically addressed that in your data. And Dr. Smith, from a VA perspective, just maybe one quick minute each on your thoughts on that. Dr. Stern, if you want to start.
Sure, I'll start. So the express care patients the older patients that came in with a caregiver, whether it was a child or someone else, definitely had familiar help with how to orient towards this new platform for delivery. We didn't specifically look at that aspect of it, but it stands to reason that they indeed adopted it with a little bit more ease given the familiarity. But it was surprising to us how many older adults came into our fast track area unaccompanied. And even though they'd never had any experience like this before, especially having walked in thinking they were going to go the regular route, that they were eager and even full of joy and excitement about trying something new, probably also knowing that their complaint was low acuity and that it wasn't ultimately going to result in a hospitalization. So it's something to look at.
Thanks. Dr. Olson, how about with your data?
Yeah, I would just say that the patients that I encounter, just from my experience during these shifts, they don't want to come to the hospital. they don't love this. And so in general, it's just win-win-win. I can really say that. One that comes to mind is just like a daughter who was doing a lot of wound care for the mother, and it looked fine, and she doesn't have to come in, and they didn't have to drag on her, and the whole bit. I mean, you really see it in the moment. You put yourself in their shoes, and everyone's happy with the outcome. So, and you can easily check on them the next day the same way if you have to. So it's really good.
Dr. Smith, any final thoughts from you?
My very first night on April 3rd, I took the first shift. Two of my first evening patients one was 80 and one was 99. and they were both, they both operated everything themselves. And even the 99-year-old with his iPad. He did have his daughter join the virtual medical room from a different location. And so I think they're so happy. I mean, every new provider who had joined just couldn't stop talking about how satisfying it is for everyone.
No, absolutely. Couldn't agree more. Thank you. And thank you, Dr. Kennedy, for also mentioning that we've got to keep our elder abuse and neglect also forefront in our mind with these telemedicine visits, because that can be so important. And this is a window into people's home that we don't often get. And so it's a very valuable tool. So with that, it's 2:50. I think that concludes our session. Thank you to all our presenters, and we really appreciate it. Feel free to reach out if anybody has any further questions going forward.
Thank you.
Thanks.
Thank you.
Thank you.